as I had hinted earlier, is on HIV. Are we looking at a spike, or is there a reduction in the number of these cases? Of course, I have Doreen Morai in studio with me. Doreen is an HIV and AIDS advocate. We are expecting to also see Patricia Jekonaya as we continue, of course, with this conversation. Doreen, karibu sana to TV47. Thank you for being here. How are you today?
I'm fine.
Yeah. So let me just start with you now that you are here and we are ready to kickstart this conversation. What is the reality on ground, Doreen? Are we looking at a reduction or an increase in these cases?
Well, it's, can I say, it's not a win-win situation, but we are doing well in terms of now we have treatment, we have better prevention methods. We are soon introducing new long-acting preventables. So on that end, we are winning. On the end of reaching the end user now, who is the normal Kenyan, we still have a lot of work to do. We have not yet tackled the aspect of a lack of information. Stigma is still very high. New infections are still there. And sadly, people are still dying of HIV, of AIDS-related illnesses in 2024. And also children are being born with HIV in 2024 as well. So it's a very
50-50.
50-50. It's not even 50-50, but it's a very gray area situation.
Is it a margin, could we say 80-20, 60-40, 70-30?
70-30.
Really?
Yes.
So the 70 is that there's not much that has been done up to this point. And when you talk about treatment is now available, what are we talking about?
So treatment is now available. That means ARVs are now available for people living with HIV. So now testing has improved because now we are all the way, you can get to know your HIV status right from the comfort of your home. So that is a win. Also ARVs now, when you get tested, you started on ARVs immediately, so that's also a win. We are now living in the era of undetectable being untransmittable, where a person with living with HIV with an undetectable viral load cannot transmit HIV to their sexual partner sexually. So that is also a win because it's a way of preventing new HIV infections. So on the side of where we are not winning much is because we started off well for a long time, and then I think at some point the education kind of got rechanneled to more of being target population based. So you find that the people living with HIV themselves mostly know a lot of information around HIV prevention, treatment and care, but the people who don't have HIV, unless they have like a HIV scare or there's like a risk factor involved, they really don't mind about HIV. Like they don't take time to educate themselves, to unlearn the things that we have learned growing up from school and all that, to relearn what is new in HIV as of 2024. And I think that is where, that is the gap that we're yet to fill. Yeah.
All right, of course, we have statistics, of course, as of 2023 in this worry list this week.
Yeah.
Today is a new week, right?
This is a new week, so last week.
So last week by the Cabinet Secretary of Health and the NSDCC, that is the National Syndemic Disease Control Council. Now, as of 2023, total new infections are 16,752. Of course, as you can see on your screen, children are 3,743 infections and adult 13,009. Of course, that is a reduction from 2022. In 2022, there was a spike, Doreen. We had 22,154 cases. Children were 4,474 and adult was 17,780. Of course, we could go on and on down to the 5 years, but I could bring Patricia at this point into the conversation. Patricia, how are you today?
I'm fine, and good evening. Thank you for having me.
All right, karibu sana. We're glad that you're here. Now, I just asked Doreen this question, and I would like to also throw it at you. What is the reality on ground, Patricia, from LVCT perspective? Are we looking at a spike in these cases, or is there hope that we are doing okay as a country?
Right, thank you very much, and great to see you, Doreen. So if I reflect back to when we started the fight against HIV, we had committed that by 2020, we would be having less than 20,000 new infections. And unfortunately, we were off track just based on what you have shared with us from 2022. But when we look at the data right now, it is quite promising. It shows that there is a lot of work that is going into HIV prevention, for example, because for the longest time we have adolescents and young people aged 15 to 24 years who continue to contribute about 41% of all the new infections, with women being more affected than the other population. So I would say in terms of HIV prevention, there's a lot of effort that is going into this, including introduction of new HIV prevention technologies, which is some work that I'm also leading with a team in the country. And if I could just speak briefly to prevention, to care and treatment, which means enrolling people who are living positively with HIV onto treatment. I think that's one place that we can definitely do better. Reflecting on the data in 2023, we had children between the age of 0 to 14, about 77% of them being able to access, 15 to 19 years, 75%, 20 to 24 years, 64%, and then 25 years going up was about 102%. So it means there's quite a lot of work that we need to do right from 0 to 24 years for us to meet the global targets of 95% of all people living with HIV being on care and treatment.
All right. So Doreen says, Patricia, that we started off well, but along the way, something happened. What exactly? Where did the rains start beating us from?
I think there are a number of dynamics. If I could speak to specifically, let's start with prevention. For a long time as a country, there are conversations that we've been afraid to talk about. And especially regarding young people, you find that the information around how the transmission happens, what to do for one to prevent themselves, is information that is not generally given to young people until, say, they reach the age of 18. And what we are seeing is that we have people as young as 15 years who are getting infected. So it means we have to rethink how we do our prevention messaging, how we cascade the information amongst the adolescents as they grow into being a young person, into youth, that this information is something they need to interact with early in their lives. And around care and treatment also, there's a lot of stigma. There are still parents who do not want to put their children on care and treatment early because they feel they would be stigmatized. We have had a lot of treatment interrupters. These are people who started on their medication, but somewhere along the way, for various reasons, they drop. So part of the efforts now is to ensure that, we are going back and we're getting everyone who dropped to come back into care and treatment so that we can close the tap when it comes to infections, and ensuring that adolescents and young people have the right information to make the right decision when the time comes, so that they can prevent HIV, and we say as a country that we have actually closed the tap. But I think also the other thing is that we have been over-reliant on donor funding. And so we rely a lot on external funding to really fund HIV work, which I would say it is a high time for our government to also increase the investments in HIV programming.
I'll be coming to get more on that comment about we are getting help from the external sources. But I want us to take a look at some statistics from a release by the CS, and that is HIV infections are down by 83%, that is in a decade. New HIV infections 101,560,000 in 2013, reduced to 16,752 in 2023. That's quite a good work. Yeah. Now, people on antiretroviral therapy, that is ART, doubled to 1,336,681 by 2023. AIDS-related deaths, 65% reduction from 58,446 in 2013 to 20,480 in 2023. Now, HIV, when we look at the viral suppression, 97% of people on ART have achieved viral suppression by 2023. Now, when we say viral suppression, Doreen, what do we mean?
When we say viral suppression, we also mean these people are undetectable. So the ARVs are working for this, the most simplest definition.
Right.
So the ARVs are working. Why? Once people start taking medication, the viral load goes down. So the level of virus in the body goes down. As long as it's suppressed, this is a person we know now who is taking the medication well, they're living a healthy, normal life, they cannot transmit HIV to their negative partner, and for women it also boosts the reduction of giving birth to a HIV negative baby as considered to a person who is totally not on any care and treatment. So that is a win. So when we maintain a stable viral load for people living with HIV, that is a win. Yeah.
All right. Now, you know, I was having a conversation with a friend last week concerning this, the undetectable part of context of this HIV. And this friend was asking, how is it possible for a partner to have HIV and this other one to be free of it? So there's still fear that if this one maybe akona HIV and to use the famous ahanye ukonje, maybe he or she will bring this virus to this other partner despite being undetectable at that time. Is this true?
So the positive one is the one that is kind of opening the risk, or the negative one?
Well, both. Let's just go with both.
Okay. So in a perfect scenario, in a perfect setup now, two people, a discordant couple. One has HIV, the other one does not have HIV. So that is what we call a discordant relationship. This one on the HIV positive one is on treatment. They have an undetectable viral load. That means they can't pass it on to the negative one. That is what we call treatment as prevention. So they're using their own setup to prevent. So this is assuming that they are faithful to each other. So nobody is putting the other at risk because this one is on treatment, this one is faithful to this other one. So the risk comes when, for example, now this one who does not have HIV decides to risk and maybe have another extramarital affair with a person who maybe they don't know their HIV status. And remember, they're not using any form of prevention out there because at the back of their minds, they know that they can't get HIV from this positive one at home, but they're like, yeah, I'm good. So because of that lack of putting prevention methods at work, they might end up getting HIV from another partner because this partner at home who is taking the treatment is not going to give them HIV. But the one who doesn't, they are already at risk of getting HIV because they don't have, and they are risking themselves engaging in different sexual risk behaviors. So when they get a HIV infection, this is where I will need Patricia to come in. I don't know whether a reinfection can happen to the undetectable one, but the undetectable one cannot infect this one. So it is the negative one as well to ensure that you remember the ABC, abstain, be faithful? So the be faithful part is actually adhered to. That way there is zero risk here. Yes.
All right, Patricia, now that is where you come in, just as Doreen says. Who is at risk?
Right. Thank you so much. And Doreen is quite right. And I just wanted to add that also what we know is that viral suppression is not a static state. If, for example, the person who is positive and is on medication compromises taking their medication in one way or the other, it affects the viral suppression.
Yes.
And so if the viral suppression is compromised and it goes down, there's a likelihood that they can actually transmit the virus to the one who is HIV negative. And if the HIV negative one, in the case example of what Doreen has just shared, that they go out of their union and meet with someone else, and then they get infected. Now that becomes a problem because it could be a different strain that then predisposes the one who is HIV positive and is virally suppressed for their treatment to be compromised. So it's very important that both parties, take preventative measures. The one who is positive ensures that they are constantly taking their medication to maintain viral suppression, and the one who is negative is preventing an infection because it could have a negative effect on the one who is living positively.
All right, now we are saying that this negative partner also, does he or she have to take medication every now and then, despite, especially if they're getting intimate? So do they have to, does he or she, this negative partner, anatumia protection PIA?
It is usually advisable. Right now we are championing for something called the Choice Manifesto. The Choice Manifesto is where we have all this basket of choice of HIV prevention. So, which means it's not, you can always combine different prevention methods to ensure that you're reducing the risk of getting HIV sexually. So, for example, if your partner is, there are people, because we're human beings, they start medication, they're virally suppressed for a while, they decide, I'm giving myself a treatment holiday. See, a person like that one, it's good for the negative partner to either incorporate condoms, incorporate PrEP as well, to ensure that the risk is averted at any point. So because we are human beings, so we have to always incorporate that aspect of risk. The negative partner as well can always just be on PrEP for the aspect of safety. Now we have what we call the vaginal ring, the PrEP ring.
I was coming to that, the vaginal ring.
Yes, so they can, especially if it's a she can always use the vaginal ring as well, because it's also a HIV prevention method. So yes, my partner is undetectable, but to put the prevention at 100%, we are going to use the ring, or we are going to use PrEP, or we're going to use a condom. So that's why I said it's a basket of choice that you choose what works for you and incorporate it. So HIV prevention, we need to look at it from a point of, it's not just 1 + 1 = 2. It is a different, what is it called? It's all these amazing choices that you can choose from and then ensure that you're working with them.
All right. Yeah. Now, Patricia, vaginal ring is something that is not talked much about. There are people who don't know there's something like that. Personally, I heard about it 2 weeks ago. So how, for sure. So how is its accessibility in the country? Is it easily accessible, this vaginal ring? Tell us about it.
Right, thank you very much. I'm one of the champions of the vaginal ring. And I talk a lot about it in the country for those people who may find it as one of the methods that works for them. So it's a pre-exposure prophylaxis, meaning that you use it to prevent HIV. Now, the vaginal ring currently is not widely available in the country. It's only available now in about 6 facilities in Kenya, in Nairobi, in Mombasa, and in Kisumu, within an implementation science study. And for implementation science means we are answering questions that would be useful to inform how to introduce it widely in the country. So we do look forward to having it, having more rings in the country, probably in the coming year, together championed by the Ministry of Health. And so currently what we are really working on is collecting the evidence to draw the confidence of people in utilizing the ring. We have found women who have decided that for them, the method they want to use to prevent HIV is actually the ring. And we have a good mixture of women who are using it, both who are exposed to higher risks and others who have moderate risk, and they're utilizing it. And I think so far we are happy with what we are seeing. There's hope for the women who will actually want to use it. And I think the one thing that is also good with the ring is that it is quite discreet. So for women who initially faced, gender-based violence or intimate partner violence because they were taking the pill daily. Now this is one of the methods that they find quite useful because it is discreet unless they decide to tell it to their intimate partner.
Yeah.
I hope our viewers can get that point, that this is something very discreet that your partner cannot really realize that it's in there. But Patricia, is there really side effects of PrEP? Now, why can't it be accessible like mara moja, venye naenda pale nataka mara moja? Who gets PrEP?
Okay, who gets PrEP? Okay, so now I think this is quite interesting because now we have moved to talking about PrEP as a category of products. And I will just quickly speak to what that means. Initially, what we had in the country was oral PrEP, which is a pill that one would take daily as long as they are at risk of getting infected with HIV. Now, there were a lot of, feedback in terms of how it is packaged, the side effects. Some could not tolerate, the nausea they would feel, and even keeping the drug somewhere where it is safe and discreet. So with that kind of feedback, scientists on the other side, take that feedback and then begin to develop products that respond to the challenges that people are communicating. So then we got the dapivirine vaginal ring, and I don't know if you're able to see it clearly on the screen. I'm just holding it. And this particular one it is not a systemic tool. So it has a drug called dapivirine. And what it does is that once it is inserted in the vagina, it begins to release the drug called dapivirine that is localized within the vagina. So what that means is that there are no major side effects because the drug is just concentrated in the vagina. So what we encourage people to do, women who are using it, is to ensure that their hands are clean. So that we also avoid things like the urinary tract infections. But also there are women who've reported, they get more discharge when they have the ring on. But the side effects are quite, manageable, and they go away after a short period of time. So for the ring specifically, in a week or two, once you become comfortable with it, you should be okay. And then we have a new drug that is coming into the country. It's called the long-acting injectable cabotegravir, which now people will be able to use it. It's not specifically for women. And the ring, for example, you have it on for 28 days. And then if you're still at risk, you remove it and put on a new one. For the injectable, it works differently. So you will get your injection. Say this is the month of November. So I inject you today. You come back in December for your second injection. And then from there, every 2 months. So I see you in February, I see you in April, and you take it, you use it as long as you are at risk. And I think that for us is the message that we really want people to get. You don't use these products for life. And what we have learned with human behavior is that risks of individuals keep shifting from time to time. So when somebody realizes that they're at risk, what we are saying is now the basket of choice is more.
All right.
Yes, and they can choose.
Thank you so much, Patricia. We'll be getting back to you in a few, but of course, we are learning, and I hope our viewers would agree that today we are in class. Like the vaginal ring, I'm also seeing it for the very first time, but we're taking a very short break at this point. Of course, this conversation is very interesting, and we're coming back with it, so don't go too far.